Hey, this is Brandon with ChiroUp. We're going to go through a quick class on labral pathology. Most people would consider this more of a slap tear type diagnosis, but realistically, this is a diagnosis associated with instability. Just like every other diagnosis we see in the shoulder, we see this joint that sacrifices stability for mobility. And when that happens, there are certain constraints that take a regular beating, essentially, and that being the labrum in this case. In fact, what we're going to see with the labrum is that this is involved with a lot of different diagnoses, meaning we can have rotator cuff tears, we can have biceps tendonitis, we can have, actually degeneration of the joint, all in combination with labral pathology. It's not often we get an isolated labral pathology, and when that's the case, it's due to a specific sport, a specific trauma. Most often, we're going to see these things be more degenerated as far as a general failure of the tissue. Now, the acronym SLAP is really going into more of a detachment of the shoulder superior glenoid labrum. This is what's going to anchor and kind of hold in the head of the humerus onto that glenoid. We are very fortunate on the top of that glenoid, we have still the biceps tendon, but the biceps tendon goes into the labrum, and 50% of it's a part of the labrum. So there's a combination of tissues that we're going to be working with, but realistically, we're looking at a simple fact that this is about a quarter, 25% of people who are going into surgery have labral pathology. It's a big part of the population. So we need to make sure that we know when it's a surgical problem, when this is an isolated lesion, or this is just part of the process. It's kind of like having hamstring or hypertonicity and back pain. So does everybody. So when you have labral pathology, it doesn't always mean you have to surgically repair that. Instead, it's more of a sign of dysfunction. So when it comes to the actual labrum, this is more of a fibrocartilage. It's a circumferential ring that goes around the humerus and provides some excess support. It's kind of like the meniscus of the knee. Those meniscus are not very big, measured in millimeters. However, with the glenoid, it's only 5 to 7 millimeters deep as far as a concave surface. So we have a round ball, which is the humerus, going onto essentially a flat surface of the glenoid. We need some extra stability, and that's what the labrum is there for. So it doesn't have a very secure union like the meniscus does, and that's why we start to see it pulling away or tearing away or detaching from the spot because of all the activities and the things that we do with the shoulder. So what we have here is this very top piece. The good part about the labrum is that 50% of the fibers from the long head of the biceps insert on the labrum, which can add to its stability and pull, and 50% actually attached to the top part of the glenoid. So it has a bony union, which adds to that support. So it's a good piece that on that supraglenoid tubercle, we have a little bit of excess stability in a joint that, once again, does not have great stability. What we see, though, is this hypermobility of the glenoid, or the glenohumeral joint, is that this labrum, the capsule does get stretched out. We'll see that with impingement syndrome. We'll see with rotator cuff syndrome that this humerus is starting to migrate superiorly, and you have excess motion. So the labrum is going to increase that concavity of the glenoid by 5 to 9 millimeters. And so that doesn't sound like a lot, but that's actually a 50% increase in that depth. So it does help with that articulation. Unfortunately, just like the meniscus of the knee, though, this is just fibrocartilage. It's not very vascular. It doesn't have a good ability to heal. And once you tear it, unfortunately, it kind of stays that way. So there are certain aspects of it that are irreparable. However, they don't always have to be surgically fixed. And a lot of it has to do with the things that we do. So if you look at the etiology of a lot of these labral lesions, very few of them occur to a traumatic injury. More commonly, it's going to be a repetitive, it's going to be a micro trauma. It's repetitive overhead, sports. It's a job like painting ceilings with your arms constantly up, or even just holding your arm up like you're holding a mouse all the time. It's that competitive superior translation of the humerus up into that area that can cause these kind of issues. Now, it can be traumatic. A third of all isolated SLAP lesions are due to a traumatic onset. And most commonly, when that is the case, it's a FOOSH injury, a fall on an outstretched arm. So we'll see that. But what else will you see when your arm hits and it gets jammed upward, that superior translation? Not only are we going to get injury to the labrum, but we're also going to get injury to the muscles that are responsible for holding that humerus down, and that being the rotator cuff. So I would highly recommend looking into those tests also, and that's in a previous class for the rotator cuff. When it comes to symptoms, and I am the unfortunate recipient of a labral problem. I did play a lot of sports and overhead athlete sports all the way through high school and college. And one thing that I noticed, and what we see the same thing here, is that yes, it is provoked by overhead activities and bringing your arm across your body. But realistically, it's more just a deep-seated, vague discomfort. And I noticed it after playing several years of sports. And now when I go to throw a baseball or a football, I still can throw it. I don't have the same velocity, but I am a little bit older. But I don't have the accuracy. I don't have that feeling of stability in my shoulder. And I never had mine surgically fixed. I know it's there. But I do a lot of strengthening type exercises to essentially compensate around that. Try to build stability elsewhere instead of doing the surgery. Maybe that's in my future, but not yet. And that's what I see here most often, is that looseness. It just doesn't feel the same. I can't really pinpoint a specific pain or a problem. Every once in a while, I'll strain something, and just being a chiropractor, we do a lot of stuff, and definitely with our upper extremity, where I will have a sore shoulder every once in a while. Whether that's due to a labral lesion or not, I'm not sure, but I can't imagine it's helping the issue at all. One thing that I got to be honest with you, when I first got out of school, I didn't even realize this, essentially to the same extent, is that this biceps tendon, we think of our bicep as literally that, just our bicep. It's down here on the arm, but that tendon of the long head goes all the way up and inserts on the glenoid. Well, when we talked about the rotator cuff and we talked about the purpose of the rotator cuff, we said a big piece of that puzzle is to hold the actual humerus head down. And if you don't have it down, it's going to start to migrate upward. And we have muscles that are responsible for that, being the rotator cuff. Well, it turns out the biceps tendon, and you can see that here, also has a very good pull. It can provide a compressive force to the shoulder. It can provide that downward force and traction to prevent it from migrating up and creating signs and symptoms associated with impingement. And we'll see that here with this picture, is that, depressing the humeral head, that wasn't on my, my test when I was taking classes. You don't hear about that with the biceps. We think of the biceps as an elbow flexor, a shoulder flexor. We think of all those things associated with the biceps, but one of the other things to think about is it also has a stabilizing function to the shoulder. So something else to consider. Now, one thing about the shoulder is that it doesn't have very good stability, and we see that happen over and over again. It's designed for mobility. Unfortunately, or I should say fortunately for us, we find ways to compensate around that. So once you have periods where you have an injury, a problem, a lack of stability, a tear, what have you, your body's going to start to move differently. And unfortunately, we can compensate in a number of ways, but we normally see people start to bring up their arm or bring up their shoulder, more of a Gothic shoulder type situation. And we see this weakness in the rotator cuff muscles. We see an issue with the slap tears. We see all of these things happening at once, but fortunately people are able to adapt around it. until unfortunately at some point they're not. Only 28% of slap tears are isolated problems. That's telling us that a big chunk of these are just a part of the degenerative continuum. You can have other things like Bankart lesions, in different spots of the labrum. You can have things like AC arthritis and supraglenoid cyst, and a cyst being that friction is causing fluid-filled sac, usually the bottom part of the shoulder. But unfortunately, these things happen over a long period of time as compared to an insidious onset or a traumatic onset. When it comes to classification, and I'm not someone who does a lot of measuring in their office. I really do look for elephants in the room. However, when I get an MRI back and I'm looking to this patient and I'm trying to give them an accurate prognosis, an accurate diagnosis of what's going on and what we can do about it, this is one of those times that I'm going to want at least an idea of what is surgical and what's not surgical, meaning what should stay in my office as far as patients versus what would maybe be better co-managed with a different office, and then maybe come back and do some rehab with that patient. Well, here's what most of the research said. This is a classification by Schneider, but this is the most widely accepted classification system that I can find in literature. And really what we see is that these type 1 and then we'll see type 2 lesions are the vast majority of issues. It's showing a sign of instability. This is when you're having a little bit of fraying, a little bit of degeneration, but the actual labrum is not being pulled away from the glenoid. When we see this is a sign of instability. It's a sign that we need to make a change, that the person has been doing something or currently doing something, that we need to make an intervention. And then once they hit type 2, now you're starting to see some detachment, showing signs of either longer term instability or a greater amount of instability. And this is when you have a less stable biceps anchor. And unfortunately, when you go to use the bicep, it can actually pull away from the glenoid attachment. Even when we see these though, this still falls within our scope. This falls within something that will respond to conservative measures. It's not until you hit this period, and this being the type 3, when I see the word bucket handle displacement, and a lot of times you're going to see that actually on the MRI report, this is when you look at the surgical reports, these people don't do well conservatively and possibly need a little help. And that little help is a screw that reattaches that glenoid. Now, I'm not saying that everybody has to have surgery for this. It really depends on the person and their what they really want to do with their shoulder. If it's someone who's 80 and has no intention of playing professional baseball again, probably doesn't have to be repaired. Someone who's in their teens or their 20s, it might be at least a consult with an orthopedic surgeon. Now, when you look at the gamut of people who have surgical or have slap lesions, less than 10% of people have these kind of a problem. So this isn't a big piece of the pie. Most of the people have other issues, and more of the type 1 and type 2. Type 4, this is when you're starting to get rupture of not only the labrum but also the biceps tendon, and it's very unstable at that point. In this type of situation, that's when I'm definitely going to call in an orthopedic surgeon if that person's wanting to get back to normal activity, because the simple fact is their structure now is going to permanently affect their function. It'd be very difficult to get them to get back to normal function in a type 3 or type 4 type of issue. So if you've already seen the lectures prior, what you'll see are these gray boxes or green boxes on prior lectures, and it really just goes over the evaluation, the management, the imaging guidelines, and also the exercises. And this is not my opinion. This is all based on evidence-based information, the best information that we could find, profession independent, bias independent, what we can do for slap lesions. And there are several tests that we can use. I'm going to break it down to only the most specific and sensitive tests that we can find, because I think that those are the ones we really need to be looking at to do in our practice to keep us efficient in what we do. So let's go over the evaluation first, and then we'll go through the management tools and also the exercise at the very end. When we go through a SLAP lesion, we really are looking for glenohumeral instability. You can imagine that a lot of these patients have already gone through the diagnosis of dyskinesis. They've already gone through the diagnosis of impingement and rotator cuff syndrome, and now they're going into possibly a SLAP lesion type diagnosis. So we need to be able to identify and really isolate that tissue to see if there's something we can do to alleviate it, alleviate the symptoms associated with it at least. The first one is the biceps load test 2. And this is my favorite test. And the reason it's my favorite test is just because it's in the position that I already have a patient in. So a lot of times I'm going to select tests based upon their sensitivity and specificity. Fortunately, this one fills 2 buckets for me. However, I do a lot of my shoulder orthopedic examination from a seated position. So now we can go ahead and do it from right here. And when we do this biceps load test, we are going to put the patient in a very unstable position. A lot of people with shoulder problems don't like going into this range of motion. So keep that in mind. Support the arm. You're about 120 degrees of flexion, abduction, and then you're rolling her back into further external rotation. So that's a very unstable position for this patient, and some patients don't like doing that. And that's okay, you know, that they don't like doing it, but you really want to get some information on this. So I'm going to play it one more time, because if you can notice from my right arm, I'm going to support her the entire time. When she gets to this position, I'm going to let her know that we're going to arm wrestle here, but you're going to let me win. I'm going to push and you're going to resist. So she's going to be activating her bicep at that time, and then I'm wringing that bicep out. I'm pulling at it. And when you pull at that bicep tendon that attaches to the glenoid, it's going to reproduce symptoms if there is a lesion at that level. So that's probably my favorite test when it comes to the biceps and looking for labral lesion. Possibly a little bit better, just because you're taking out gravity, would be the compression rotation test. So this is going to be very similar to the biceps load test, but now you can eliminate those postural muscles that are holding that shoulder girdle up. So what you're going to do with this test is, now that I have her laying down, usually patients a little more relaxed, I'm going to stabilize the shoulder, I'm going to push in, and now I'm just going to rotate through internal and external rotation, and I'm going to be looking for any kind of popping, clunking, pain, those kind of things are what I'm looking for. And right, my left arm here, I'm taking my elbow and driving it through her elbow. So we're going to create a compression there. As you can imagine, if you have an intra-articular problem and you go to drive and compress those 2 tissues together, they're probably not going to like it very much. I have had several patients who have had issues with this, and you will hear a grinding or a clunking sensation with those patients. Now you can do that from this position, which is, I think, possibly a better test, or the more popular test, maybe because it's just a little bit older, I'm not quite sure, but you find this test in the literature a little more often. This is going to be a very, very similar test, looking for the same kind of findings, but now you have the patient seated. I find that this is a little more difficult to do. One, you have to get my elbow up to drive through her elbow, and it's very difficult to use your hands to go into internal and external rotation. It's not to say it's not a good test, it's just a little bit more difficult to do it in this way. I have also found that I can elicit a popping or a clunking sensation with the compression rotation test, whereas I don't get it with the crank test. When you are sitting, you do have postural muscles that are active, and I think that when you're really looking for passive structures that may have failed, it's best to offload that joint as much as possible to get to those end ranges to test out those passive structures. So those are my favorite tests for the labral lesion. As it turns out, those are also one of the most sensitive and specific tests for a labral lesion, and they work really well to identify a tissue source of pain. When it comes to imaging, I'm not a radiologist. I'm not a DAC by any means. In fact, in all of our references, you're going to see this imaging recommendation. We have 2 DAC who work with us, who are generous enough to provide the current standard of care for all the different diagnoses that we talk about. And sometimes the literature does change. What we learned about in school may not be the best thing to do for today's patient. However, we try to keep up to date as possible. So we can look at what are the actual imaging recommendations. And of course, we have to be assessing for everything. We have to be looking at every possibility when it comes to any kind of a diagnosis. But with SLAP lesions in particular, we have to have a high degree of suspicion, because a lot of times, when we said, there are coexistent pathologies. These people may have other issues that you're going to find on the imaging, and it's always good to marry the history to the physical exam, and then in this case to the imaging, to make sure that we have the right structure that's causing their pain or their problem. So we really need to make sure that we understand what is causing their pain, because sometimes we can have a SLAP lesion showing signs of instability, but you do all your tests and it's negative. It's not, it does not reproduce any other pain. It could be coming from something else. So when we do look at imaging, what are the appropriate tests? I'm not going to tell you that an X-ray is the best way to visualize an actual SLAP lesion, because it's not. Radiography is a bone study. But what do you see here? So if you look on the right side, you're going to see a nice matchup between the humeral head and the glenoid. And when you go here, you can see how the humeral head has slid up. I can't tell you this person has a labral lesion, but if I had stuff that was attached to the top piece of this, like the labrum, like the biceps, like the rotator cuff coming across there, I can tell you all those structures are going to be stressed. All those structures are not doing their job because you have migration of the humeral head up, whereas in this case they don't. So while I can't tell you that they have a soft tissue problem here, I can infer there's something going on based on that migration, that superior migration of the humeral head. So that'd be the first thing to at least take a look at as far as radiography and ruling out other kinds of issues. For those of you who do diagnostic ultrasound, this is one of those things that can kind of highlight how much that I know about ultrasound. Does anybody know what this is? This is a normal first month in pregnancy. To me, it looks like the weather front moving in. So by no means am I the expert on this. However, I do want to bring it up because I am seeing a lot more diagnostic ultrasound in today's world, and I do like it. I like the fact that we can see things in motion. We can get a better idea about the physiology happening at specific areas with diagnostic ultrasound, and with tissues that are close to the actual surface, like a shoulder, like an elbow, like a knee. We can see a lot of cool things with diagnostic ultrasound, and we're seeing the sensitivity and specificity of these tests is very good in comparison with MRI, and is at a decreased cost. So once again, I am not the expert when it comes to imaging. However, diagnostic ultrasound, if you have someone in your area, and there are a lot of chiropractors doing this, that you can find someone to network with to maybe look at things that may be a little bit differently. Now, when it comes to the use of MRIs are very useful in looking at soft tissue. What we need to do is we need to figure out what to do, what to order. And a lot of times when you're looking at hips and shoulders, you want to order this as an arthrogram. And the reason we're going to do that is because when you can throw a little gadolinium in there, you can see the actual bone structure. You can get into the capsule. You can see cartilage defects. You can see labral problems. So it's the highest sensitivity and specificity for detecting SLAP lesions is going to be an arthrogram. So make sure you're ordering that. And if you're not, and that person has to end up going to surgery later, then they're going to have to order at a different time period, and you're just in the same test twice. So once you get a diagnosis and you do all these images and you have this patient with this shoulder pain, I think that the biggest piece is, does it really matter? Meaning, are you going to do anything different for this patient? A lot of times I'll have a patient, and it's the first time that I see them, and I'm suspecting a SLAP lesion. Do I need to jump into X-ray, MRI, an expensive test? Sometimes I do. Sometimes if that person is high school baseball pitcher and they need to get back into next season, we need to make sure we have all the answers to give them the best possible prognosis and idea of what to do or what to pursue as far as care. Other times we maybe don't. Other times, somebody is, 65 and is an accountant. Maybe they don't really care if they have an MR problem or a labor problem because they're not going to get it surgically repaired now, and a trial of care would be more appropriate. So really, when you do this, you need to make sure that you understand your audience. There are some 60 and 70-year-olds that really want to get out. They want to be active, and that's a population that I'm going to be a little more aggressive and give them all the information and all the possibilities they can pursue with that diagnosis. They can weigh out the costs and the benefits on their own, and I'm just here to help them along that process. Now, when it comes to the management of labral lesions, there is a little bit of dispute on this. A lot of people will really try to stretch out this area and get the joint moving good because they'll find deficits in range of motion. And other people will go right into more of strengthening exercises, and other people go into more stabilization exercise for the scapula. I'm going to try to make it easy on myself, on you, and also your patients with the exercise program that I think would be most beneficial that we can find in the literature. But as far as management, let's go through really what we need to be at least looking at for these patients. The first one being soft tissue manipulation. What we said is when we're looking at these biceps problems is these patients have issues as far as the biceps being pulled because of that labrum or the glenoid going too high, the humerus going too high. A lot of times the biceps be holding on and be very sensitive as either a reactionary or the cause of the actual labor problem. So doing things to help loosen up that muscle and desensitize that muscle, like something like a movement stripping like you're seeing here, or even going into more of a contract relax stretch like you'll see here, where I'll put my hip right in front of her and she'll push into my hand, relax, and go a little further. Those are all ways that we can stretch out the biceps, even including instrument-assisted manipulation. Now, that's good. I would just be careful. And the reason I'd be careful is that whenever you're doing any kind of stretching for the biceps, which just happens to have the attachment next to into the labrum, and there's an instability there, we don't want to get too vigorous with it. So I would be very judicious on stretching that area and making sure I'm not causing any kind of sharp pains. I also want to work the front part of the anterior capsule of the shoulder, the spot that will often have a lot of muscle hypertonicity. Stretching out the pec major and the pec minor can go a long way. Doing some just ischemic compression or some movement stripping and really stretching out the pec minor and major. The pec minor, you want to dive a little bit deeper in there. And I think that one thing that some people may not do is lay that patient down. When they're laying down, those postural muscles are not active and you're able to get a better range of motion. Also keep in mind is that people with shoulder problems don't like moving their arm very much to begin with. They definitely don't like moving it back into extension and arm into external rotation. And so this stretch would violate both of those rules. So you really want to be careful and explain to the patient exactly what you're going to do before you do it. As far as soft tissue manipulation of the upper traps, anytime you see an X on here is where there's a trigger point per Travell and Simmons. We'll see a lot of hypertonicity in the upper trapezius on everyone. So we'll do soft tissue manipulation in office to help desensitize that tissue and stretch it out. But realistically, I'm going to find ways for the patient to also do this at home to account for that. I like contract relax stretching like you see here where she's pushing into my hand for about 7 seconds, and then I'll push back forward. So those are easy ways to stretch out the muscles that cross the shoulder joint. As far as the rehab, when it comes to SLAP lesions, there is some discrepancy, like I say, and everybody has a little bit different ideas. When it comes to the American Academy of Orthopedic Surgeons, they really want conservative management prior to surgical intervention, meaning they want 6 to 12 weeks of conservative management, meaning soft tissue and rehabilitation before they do surgery. And the reason is a lot of those people are so degenerated, they don't have good range of motion, and that lack of range of motion will limit the success of their treatment. So we really want to make sure that before that person even goes into surgery, our goal should be, one, pain reduction, but also to enhance mobility, and then to teach the patient how to restore strength to that area. For just a quick, flashback to impingement syndrome and scapular dyskinesis, one of the things that we talked about were increasing scapular stability. And when you can do that and you can posteriorly tilt the scapula, it can go a long way in providing a nice stable base for those rotator cuff muscles and really all the muscles of the shoulder to attach to. So I really recommend going back to those two classes and looking at those exercises we did for scapular dyskinesis, because a lot of times with labral lesions and in future classes like frozen shoulder, you'll see that you can make dramatic gains in shoulder mobility, meaning glenohumeral mobility, and restore strength at a faster rate if you can teach a patient how to stabilize their scapula. Once they learn how to get into a better position, they will have better mobility. And we can all appreciate that when you're really in a bad posture and your head's forward, and even when you have an anterior head carriage like this, just by bringing your back into a cervical retraction, that will improve upper thoracic spine extension, which can also help with shoulder mobility. So a lot of the things that we do that we don't necessarily think are directly related to a SLAP lesion can make a dramatic impact on pain reduction, enhancing mobility, and restoring strength. So don't forget about those things. The last piece of that, as we exit out of more of the management side, is that sometimes these people are getting ready to go to surgery, or they've just had surgery. And what we've seen with these patients after they've had surgery is they're stuck in this sling for a long period of time. They'll start to experience a lot of stiffness, pain in those neck muscles that attach to the shoulder girdle, the upper trapezius, the levator scapula, the scalenes, the SEM. All those other muscles have to do extra work to move that arm around, and now they're essentially lugging around dead weight. So even though you may not be able to treat them for their SLAP lesion after a surgery, we can definitely still attack with spinal manipulation the upper thoracic spine and neck, and we can do our myofascial release to alleviate symptoms associated with a SLAP lesion or post-surgical. So when it comes to the exercises for the SLAP lesion, really we're going to divide this into two pieces. One, the phase one is the initial stuff, and then phase two, more of the strengthening type stuff. What we'll see here though is that we're going to be using an assistive tool. The tool for this one is a rod or a broomstick. And I think that it's important to understand what the purpose of this exercise is. That if we're just doing things for quantity, it really doesn't help the patient that much. But if you're doing things for quality, it can make a big difference. So in this case, what we're going to see is during the cane flexion exercise.
Cane flexion. Stand holding a cane in both.
So during this exercise, what you're going to see is that she's trying to pick her arm up. Let's say it's her right arm that's the affected arm. Her left arm is doing most of the work. So you can still perform a normal range of motion while the other arm is assisting or helping. You can also have the end of the cane holding on to her hand holding onto the end of the cane and doing the same motion. So what I would do is have the cane here, and I'd be just coming up with it like this and holding the cane. So there's a lot of different ways you can do this. You can do it into flexion, and you also can go into abduction when you're doing those exercises. But remember, you're trying to have normal scapular motion. You're trying to have normal glenohumeral motion as you're doing this exercise. If you can't get normal motion, that's when you're going to use the other hand to help in that process. Now, here's one that you're going to find in the literature that I do have a little bit maybe of a disagreement, or I just would at least rather caution you on this exercise, is that Codman Pendulum works well to improve shoulder range of motion. So when you can do this, it does help with that. But if you have a labral lesion, the labrum attached to the biceps and the biceps attached to the arm, and you start to distract it and wiggle it around, I think you're actually increasing the amount of pull on the labrum. So I'm not saying that it's going to make the labral problem worse. I would just say be very careful with that, as I don't want to see someone create more pain and more inflammation in the area with Codman Pendulum. I don't think I'd weight them down hard with a 15-pound weight while doing this exercise. Possibly my favorite exercise is the scapular clock exercise. And the reason I like this is because the arm really is, you're changing the stabilization point. Now you're stabilized on your hand. So your body is no longer the stabilization point. It's your hand that's a stabilization point. And now she's going to attempt to move her scapula in all the different directions. So really now moving up, and she can go to the side, and she can go down, and she can go towards the spine. And it's teaching her how to actively use those scapular stabilizers. And you can see how difficult that is for her. And most of our patients will have difficulty with that because it is a different motion. We're so used to being stable at the core and moving distally. It's very odd for us to stabilize distally and to move proximally. So this is a good way to educate someone on how to move their scapula and how to stabilize their shoulder in a different way. Now, when it comes to loss of range of motion, there is one stretch that we'll see it helps out significantly. A lot of people with slap lesions will have tension in their posterior capsule of their shoulder. And if you remember from impingement syndrome and rotator cuff syndrome, we did a stretch where the hand was behind the back and pulling. And we did that because we didn't want to add compression to the shoulder. Whereas this posterior capsule stretch, which some people call a sleeper stretch, this is possibly a better stretch. And in this case, I think it is a better stretch. So for your throwing athletes who do have that loss of internal rotation, and if you look at the literature, once that internal rotation is past 20 degrees right to left, meaning you've lost 20 degrees compared to the unaffected side, that is something that can either, one, cause labral lesions, or two, at least perpetuate it. So that's something we want to manage in our office. And the way we would do that would be this posterior capsule stretch sideline. And now when you have a patient doing this, she's going to put her right arm on top of her left wrist. So she's going to go into internal rotation as far as possible, and then she's going to gently put her hand right there. So she's not pushing down right now, just keep it there. She's going to push her hand back up into her hand and then slowly relax like you see there. So she's pushing now, and then she'll relax and just let it drop a little further. So you want to do 5 or 6 of those contract relax cycles and slowly do that motion. Clearly, we don't want to yank the arm down and cause any increase in symptoms or pain with that. I think that if we can increase glenohumeral internal rotation, we can provide these patients a lot of benefit. Surgery. So one of the things that we want to focus on is that a labral lesion in isolation is usually not a problem, and definitely in a population that does not need that labral lesion, or does not need to be active as far as an overhead athlete, or maybe has a profession they really need their shoulders, like a chiropractor. But when you start to see any kind of weakness, when you start to see any kind of atrophy, you have signs of nerve compression, numbness and tingling going down the arm without evidence of a cervical problem, that could be a problem. And a lot of times when we see rotator cuff issues and labral lesions, we'll see issues with the suprascapular nerve, and that suprascapular nerve going right through the sphenoglenoid notch can cause havoc on the posterior part of that rotator cuff, being the supraspinatus and the infraspinatus. So those are problems, because when you start to create a compression or a traction ischemia to the suprascapular nerve, it can really cause a long-lasting issue. So we want to make sure that we attack that. That would be more secondary to a rotator cuff syndrome or a labral problem. And the second one being a paralabral cyst. I think I talked about that just a tad with the imaging, but when you start to have friction, you start to have aberrant motion at a joint, sometimes that capsule will start to leak fluid. We'll see the same thing in the knee with a Baker cyst, and we'll see this in the shoulder as far as a paralabral cyst. I think in isolation, it probably wouldn't be a problem. Unfortunately, in that area right underneath the shoulder, there's some pretty valuable stuff down there. There's some nerves, there's some blood vessels, and we'll see issues where you can get irritation of the neurovascular bundle because of this cyst. So essentially it would be a space-occupying lesion, a benign space-occupying lesion, but a space-occupying lesion that can cause peripheral issues. So we want to make sure that we address that. And if we see that on on an MRI, we want to make sure it's not associated with nerve symptoms or blood flow issues. Our blood flow issues sometimes are confused with a diagnosis like a thoracic outlet syndrome. Hopefully you can take a look at that lecture that will be coming up. Cost benefit. This is one that I'm, keenly aware of, is that it's expensive to get care these days. So we really want to make sure that when we do recommend something, whether it's buying an orthotic or having shoulder surgery, that we're doing it for the right reasons. And when you do look at that, it's very opinion independent, meaning we need to look at the facts. We need to look at what the literature says. And while literature isn't perfect, and I 100% understand that, if we look at 1,000 people and we say, who did good and who did bad after the surgery, it turns out that if you are a type 1 or you're a type 2 type slap lesion, chances are you probably should just live with it. Do as much as you can conservatively, but it's not until you hit that type 3 or type 4 where you're getting detachment of the actual labrum that those people benefit from the surgery. So a lot of surgeons will go in there and they'll clean things up as far as removing degenerative tissue, and I think that's okay, but I think that you also need to consider the rehab for this. Not only the rehab, which we would call like PT and chiro type exercises, but rehab is relearning what you've already knew how to do, or you need to relearn how to do what you need to be done, like picking up the jug of milk out of the refrigerator. These people are going to have 4 to 6 months of strengthening, 4 to 6 months of recovery. That's a long period of time. So it's not necessarily just getting a surgery on a Tuesday. You're going to be changing your job, changing your activities for a half of a year. And shoulder issues are very difficult to rehab because they hurt. It's a very mobile joint and it needs to be used a lot. So that's something to at least consider with these types of patients that I think I think as chiropractors though, we can have a dramatic impact on these post-operative patients. Not necessarily for the rehab, the next slide will cover that, but also, as I alluded to earlier, is attacking the secondary symptoms associated with that, the changes in shoulder posture, the inactivity because of the rehab process. So you really want to make sure that even though they're going in for surgery, hey, you have surgery next Tuesday, take a month off and then I want to see you after that, because we need to make sure that your traps and your scalenes, all those don't get all knotted up and now you have headaches, or now you have neck pain from being inactive. So there's still a lot of things that we can do as chiropractic physicians to help patients throughout this rehab, even if you're not performing the rehab. Now, when it comes to rehab, what you'll notice, and definitely with ChiroUp, is we don't do post-surgical rehab as far as our protocols. I also do not do post-surgical rehab in my practice, and it's not because I can't do it. It's not because I don't know how to do it. It's just that I don't have the space in my current practice to do this. What I found to be valuable, though, is to find a physical therapist or two, to find a nutritionist, to find a psychologist, to find a massage therapist, find the people who do what you do, who think what you think, and making sure they're in your network and you can refer people to them. I refer to physical therapy all the time for things that just those patients don't fit well in my practice. A later lecture is going to be on frozen shoulder. I think I've got a pretty good grasp of what frozen shoulder is and how to treat it. It's just not something that I treat in my office because of the long duration of that person coming into my practice. It doesn't fit well into my current paradigm. So I refer all those patients out to a physical therapist. He does exactly what I want to do. In fact, I lead the rehab with that. I just don't do it. And then I attack the secondary parts of that as far as the neck and the mid back and the lower back problems associated with it. But when you talk about the actual post-surgical rehab, if you want a step-by-step, day by day, week by week, with goals and metrics type of a program, this is a pretty good one. This talks about going through, early mobility exercises. It also talks about, which I really like, is going through and the early strengthening exercises really focus on scapular stabilization. And then I think what a lot of people gloss over or start to do too fast, they start to go into eccentric exercises and go into ranges of motion that may be painful. And one thing I like about Dodson's article here, our journal, is they really focus on isometric exercises, which can help just get those muscles to be active again, to facilitate the activity in those muscles so it can go a long way. And what we also know about isometric exercises is they will decrease pain. So not only are you facilitating and strengthening that muscle, but you're decreasing the severity of pain associated with it. That is very important in the early stages of care. So that, and then it finishes up with humeral head stabilization exercises, which are really about maintaining that humeral head over the glenoid. And when you can do that, and you can keep that joint centrated over the glenoid with using scapular stabilization exercises and doing things, in fact, I'll go right back over to it. As far as here, the scapular clock exercise, this is when you're really teaching the person how to move their arm, how to move their shoulder. And a lot of times people don't even realize they can't use those muscles. They have, scapular stabilization amnesia, kind of like glute amnesia, when if you don't use your butt enough, essentially you kind of lose it. So I really think that's going to be an important piece of the puzzle also. As far as that goes, we're not going to go through the specific exercises. You can pull that journal article if you like. Now, when it comes to a labral lesion, just to recap, what I'd like to focus on is that we can manage a lot of these cases. In fact, your type 1 and type 2 type labral lesions, those are people that should be in our office. Once we see the word bucket handle tear, once we see the word detachment, that's when we really want to consider an orthopedic surgeon if that person is wanting to go back to activity. And if they're wanting to go back to activity, then we need to consider a surgical consult with those people. As far as imaging, the best imaging, as far as studying the literature that we can find, is going to be an MR arthrogram. So don't just order a regular MR. Don't order a low field, a 3 Tesla magnet, MRI with contrast to see what's going on in that area. When it comes to treatment, we need to make sure that mobility has come back. The number one loss of range of motion is going to be internal rotation. It's probably a little more of a predisposing factor, so we want to attack that. The best exercise that we can have for that is going to be that side lying stretch, which is right. Posterior capsule stretch. Side lying stretch right here. That's a great way to help mobilize the posterior capsule, and then also work at improving shoulder range of motion. So doing cane things, doing pulley things, doing a wall walk where they can get that range of motion back will be critical in getting them out of pain, and then going into the strengthening aspect of it. But we can manage the vast majority of these cases if we know what to do and what not to do. The only thing that I would say to caution would be to, if you start to see any kind of neurovascular symptoms. So if you have an isolated lesion, that's okay. However, if you start to see numbness, pain, tingling, peripheralization of symptoms with range of motion, that's when we want to put on our thinking hat and say something else might be going on here. And then with an MR, if you saw something like a paralabral cyst, or you start to see atrophy within the infraspinatus and teres minor, leading us to believe there's possibly some overlying rotator cuff issues, that's when we want to let that person go into a different office to be managed maybe in a different way. When it comes to injections, we're not going to we covered this in the rotator cuff lecture, but things like PRP injections and blood injections that are stimulating, that help repair tissue, there haven't been a lot of studies that I could find for the actual labral lesion. As this is mostly an avascular structure, you don't see a lot of repair. So once you've hit type 3, you're probably not going to 2 to 1. Once you've hit type 3, type 4 type lesions, that's kind of where it is. But that's okay, because what we know is 24 to 30% of people have asymptomatic labral lesions and never know about it. So it's a part of the degenerative process. It's very similar to having arthritis in your lower back. You want to make sure that we recognize it. We understand it's a complicating factor, but it's not necessarily the true cause of pain and has to be fixed before we can move on. Thanks for listening to this lecture. So once again, this one is on slap lesion. I highly recommend doing the pre-lectures to this, which are your upper cross syndrome, scapular dyskinesis, impingement syndrome, and also rotator cuff syndrome. Now that we've seen this, I think that after this, the talk on biceps tendinopathy would probably be the next step. And then, of course, TOS is involved in that in the same region. So hopefully you'll carry on and look at the next lecture.